You know the words dominating today's headlines.
Private equity
generative capital gains tax.
America's chip war with China.
Bets on Fed rate cuts are sweet.
But do you understand how they impact your world and your wallet? In a world that skims the what, understand the why. Because context changes everything. Subscribe at Bloomberg.com.
Ford was built on the belief that the world doesn't get to decide what you're capable of. You do. So ask yourself, can you or can't you? Can you load up a Ford F-150 and build your dream with sweat and steel? Can you chase thrills and conquer curves in a Mustang? Can you take a Bronco to where the map ends and adventure begins? Whether you think you can or think you can't, you're right. Ready, set, Ford.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we're going to be discussing a new protocol for starting injectable buprenorphine. How are we doing tonight, Sonya?
Doing really well, John. How are you doing?
Good. I have a 4-year-old with a GI bug that just hit today, so that's sort of like it's coming at some point for the rest of us.
Oh my gosh!
It's like that show 24. The timer's in the background. You just know it's coming,
right?
Because that kid,
you have like 18 hours till it hits.
I love her to death, but she coughs all over me. She's always got sticky hands. I don't know why children put their hands in my mouth, but they do. It's just I'm going down soon.
Totally going down. And you were just saying some other people of your group are sick, so you're already covering for them. Now you're going to go next. Your group's just going to have to shut down. The patients will just have to cope without you.
Yeah. No, they can. We got to adapt.
You got to adapt. Just video visits, all video visits.
Zofran and Imodium.
And video visits.
Yeah. How about you? What's new in your world?
Not much. I'm doing well. So my group, John and I both work for our listeners, in practices that are sort of groups of docs, sharing offices and stuff. So my group, which has a bunch of people, we're doing a group field trip this weekend. We're going to the Mutter Museum in Philadelphia, the Museum of Medical Oddities and Medical History. So I'm looking forward to that.
You're going with your group to do that?
Yeah. Yep.
Interesting.
Office field trip. Not everybody's coming. Some people have personal lives, but the rest of us are going.
What percentage is coming?
I think we got 4 or 5 attendings are coming, and then people are bringing assorted friends and family.
That's so wholesome compared to my office. We're not academics like you. We're just grinding. Drinking.
Yeah, you guys work on the weekends.
Drinking Red Bulls and grinding. I'm here talking about a call change, so I want to get another weekend in the hospital.
Yeah,
anyway, it is what it is.
Anyway, I'm gonna stand next to the world's largest colon. I'll send you a selfie.
Allegedly, the world's largest.
Dude, it is huge. If there's a bigger one, I don't want to know about it.
Yeah. So, anything exciting in the news for you?
Oh, totally. It's not really news. It was a research article, but it was pretty fun. And I think it actually is important to know. I wanted to share it. It was in JAMA Network Open about over-the-counter magic mushrooms. So those of us who might be on the West Coast know that magic mushrooms are being sold legally in Colorado, Oregon, and psilocybin is now being studied as a treatment for many mental health disorders. Our current Make America Healthy Again people really are promoting psilocybin as a cure-all. And so the researchers were looking at what's really in these over-the-counter products. So they went to the store, the mushroom store, and bought 12 over-the-counter products, which were all being sold as magic mushrooms. And they basically tested them for psilocybin and psilocin, which is the active metabolite of psilocybin and the primary hallucinogen in magic mushrooms. Now, John, you already saw this article, so I won't quiz you, but I'm going to ask our listeners to guess how many of the 12 products they tested had psilocybin or psilocin in them. Everyone just take a silent guess. How many of the 12 had psilocybin or psilocin in them? Zero. None. None of the products had psilocybin in them. So a few highlights from what they found. There was no psilocybin in any of the products, including ones that had psilocybin explicitly listed on the label. There was no Amanita muscaria, which is another different hallucinogenic mushroom constituents, in any of the products either, despite being on the label. 7 of the 11 products were adulterated, meaning they had other active ingredients in them that were not disclosed. So they didn't have the things that they said they had, and they had other things in them. And these adulterants included caffeine, synthetic psilocin, kava, which is a hepatotoxic hallucinogen, cannabis, synthetic psychoactive tryptamines. They call them syndelics, which are synthetic psychedelics. And then 4 of them had no active ingredients whatsoever. So basically, none of the over-the-counter magic mushrooms being sold actually had psilocybin in them. Many contained other synthetic and potentially harmful psychoactive compounds. And I definitely will use this info to counsel patients about the dangers of these products. If anyone, my patients are interested in magic mushrooms, if any of them say that they, should they buy it over the counter or what's really being sold, I think with this article, I can say it's who knows? They're mislabeled, but they don't contain actual magic mushrooms. It's synthetic drugs of some kind. You won't know what. It's just sort of a crapshoot. So, John, have you seen patients kind of purchasing these magic mushroom products? In Pennsylvania, it would be illegal. You'd have to get it somewhere else, or get it illicitly. But having any luck or using these products?
No, I not in Pennsylvania. It's interesting. I go out to visit my brother who lives in Colorado, and this is like a thing that I hear like some of his crew talk about as, in the community, and people are aware of it. It's actually kind of genius because it's not regulated, right? I mean, you could just I can't imagine that the group that uses this is a humongous like return-based customer. I mean, you could just market chocolate and like sell it as this, and it could be a side gig for us.
I mean, that's the most effective. Have no active ingredient whatsoever. Then you don't have to worry about accidentally poisoning people and getting in trouble that way,
That's what you do. The AMJC psychedelic chocolate, and just there's nothing in it.
Since we don't have any other merch, we'll just start with fake psychedelic chocolate.
Yeah, I love it.
Oh my gosh. All right. If anybody wants to buy this, circle back to us.
Okay. Just don't say that.
Just don't say that it's fake. Too late. The cat's out of the bag. It's got to be placebo. We'll have to swear we have the good stuff. John, is there anything you want to share with our listeners this week in addiction medicine news?
Kind of very interesting. This is from The Conversation. It's about cigarette filters, and the article is called "Cigarette Filters Do Nothing for Smokers' Health and Just Create Plastic Pollution. They Should Be Banned." And, I think it's interesting. The cigarette filter was kind of created in the 1950s when we kind of finally came to the conclusion that cigarettes were like definitively bad for you, causing adverse health effects. And so like the solution was, you know what, we're going to put a filter on that. And that way that cigarette that you love is now safe. And so it kind of came from industry, almost as like a reverse marketing ploy, right? And so, what they've shown is that there's some theoretical risk that filters may actually increase lung cancer risk because they enable like deeper breaths of smoke inhalation. Interestingly, early filters actually had a lot of asbestos. So mixing smoke with an asbestos filter, that couldn't have been good for you. And actually, like there's supposed to start like a large perception that smokers feel that the using the filter actually is better for you. And really, that's like doesn't seem like that's the case at all. The filters are made of plastic, so like cellulose acetate is the most typical type. So it's a plastic that doesn't biodegrade. We're in the era of microplastics, right? Everyone's worried about microplastics. It's a microplastic, so you get some more microplastics in the brain. And actually, cigarette butts are the most littered item worldwide, with 4.5 trillion discarded cigarette butts yearly in the world. So that's kind of a microplastic cigarette butt discarded 4.5 trillion times a year. Some of the newer, just like people are kind of complaining about the fact that these are plastic and not biodegradable, some of the newer kind of green companies are starting to market like biodegradable filters as like a novelty item. So again, countering negative ideas there. And what they really talk about is, the World Health Organization and many places feel that, this really kind of promotes a false perception that smoking is good for you, that the filters are harm reduction. And actually, some places like Santa Cruz, California, they've actually already banned cigarette filters. I didn't know that. So that was kind of interesting. So, the article is basically calling for a total ban of cigarette filters because we have 4.5 trillion plastic pieces of waste a year that aren't actually doing anything but giving misinformation.
Hmm.
I don't know, kind of interesting, right?
Totally interesting. I wasn't really aware of that, but it kind of makes sense. I don't know much about the creation of the cigarette filter, but those particles that you inhale with smoking are pretty tiny, you know?
Yeah.
And you see people like they breathe in the cigarette and they blow out smoke, like the smoke is getting through the filter. So,
Yeah.
right, what's really being caught in it?
Who knows? But
Un-
yeah, maybe they should go.
Maybe. It's not nothing though, because I just read a book about animal medication, and one of the case studies was how birds will take used cigarette filters and line their nests with them, and there's so much nicotine in the used filter that it's anti-parasitic. And the birds have learned that because nicotine's a little toxic.
Interesting. Or does the birds just like nicotine?
Maybe the bird's addicted to nicotine.
I mean, we all seen those pictures of the monkeys at the zoo in China, like picking up the cigarettes, right?
No, actually, they did experiments. They infected a bunch of the birds' nests with parasites, and that made the birds get more filters for their nests than when they were uninfected.
Well, maybe they just want another cigarette because
they're
because I mean, dude, there's parasites in their nest, man. They want a cig.
It's just like at your house. There's like parasites at your house. The contagion is coming.
There's no cigarettes, but yeah, I feel like the bird is like, I'm freaking stressed out, man.
I need something. Oh my gosh. Well, hey, are you ready to hear about my article?
Yeah, let's do it.
All right. So this was a pretty sweet article. I really liked it. It was from a group, a health center called the Downtown Emergency Services Center and University of Washington. And it's about injectable buprenorphine. So the article is called Injectable Only Overlapping Buprenorphine Starting Protocol in a Low Threshold Setting, published in JAMA Network Open, September 11th, 2025. A little bit of background here. Now, initiating buprenorphine for opioid use disorder in the outpatient setting and in the inpatient, but it's even worse in the outpatient, it's increasingly difficult because of fentanyl. There's higher risks of precipitated withdrawal and harder to get people to put themselves into withdrawal for a traditional buprenorphine starting protocol. So people have been experimenting with low-dose protocols where you overlap your buprenorphine with your fentanyl or your other full opioid agonist. But they're complex, they can be confusing for patients, and they take a lot of self-management, which I know my patients have found a little difficult. However, we have all these new long-acting injectable buprenorphine products, and for people who are hard to reach, who are disorganized, these long-acting injectables have shown greater buprenorphine coverage compared to trying to take a daily sublingual dose, and that includes patients who are experiencing homelessness. So, this normally when you give long-acting injectable buprenorphine, you're supposed to give a single test dose of buprenorphine sublingual first to make sure you don't cause precipitated withdrawal. And so even to give that single test dose of sublingual buprenorphine, you have to be in a little bit of withdrawal to take that test dose. Or you have to have a COWS of 4, which is still mild withdrawal. So you really do have to go into withdrawal to take the injectable buprenorphine as described on the product label. But this was a study looking at sort of a new way to use it. So just in case anybody's not aware, injectable buprenorphine is a product. You can give it either weekly a dose or a monthly dose, and the brand names are Brixadi or Sublocade. I'll just say injectable buprenorphine in this presentation because both brands were used in this study. It was patient's choice which one they wanted. But you can give it once a week or once a month, and you reach steady state after about 4 injections of the Brixadi product or 5 injections of the Sublocade product. The clinical question in this study is a very sweet study, just, descriptive experiment of a protocol that they developed. So it was individuals with moderate to severe opioid use disorder. they had to be injecting fentanyl, and they had to want treatment for their opioid use disorder. And they chose to get this protocol, this injection-only overlapping buprenorphine protocol. They found 95 people who met this criteria, and they were at a low-threshold opioid use disorder treatment clinic. 79% were homeless. Mean age was 39, and 55% were men. So a very disadvantaged population, one that can be very hard to reach. The protocol was like this. So day one, you could take your fentanyl as much as you wanted to. So day one, you got a weekly 8 milligram injection without any sublingual buprenorphine. You just got the injection. That's the lowest dose. Day two, you got a 16 milligram weekly injection, and you could do it up to 2 days late. You continued your fentanyl. Day three, you got the monthly 128 milligram or 300 milligram, based on what brand you chose, injection. That's just the highest dose monthly injection. And you continued your fentanyl. So basically low dose day one, slightly higher dose day two, full dose day three of injectables. And you used fentanyl throughout. You were given clonidine, hydroxyzine, ondansetron to treat opioid withdrawal symptoms, and also supplemental sublingual buprenorphine after the first monthly injection. So if you were still having cravings or withdrawal, you could take additional sublingual buprenorphine. The medications were given in the clinic or carried to the patient's location in the community, wherever they were. And the outcome was the number of people that started the protocol after signing up for it, so who actually showed up for the first injection, how many completed the protocol, so 3 shots, and how many made it all the way to the second month where you would get the second monthly injection. So, John, what do you think of this clinical question?
I think it's like interesting thought, like these kind of alternative loading dose protocols for these injectable medications. I mean, yeah, I'm interested to see what it says about kind of the precipitated withdrawal and how they tolerate this.
Yeah, I mean, that's the fear, is that if you give someone an injectable buprenorphine while they have fentanyl in their system, you'll cause significant precipitated withdrawal. You know, they did have to counsel the patients a little bit. And I did want to talk about what they told the patients, because this is sort of what ended up happening. They told the patients to expect some opioid withdrawal during the 3-day process. And if you have withdrawal, you could treat it using fentanyl. There was a possibility of severe precipitated withdrawal, and they actually counseled against stopping your fentanyl for the first 2 or 3 days. So basically, try to use them as safely as possible, carry naloxone. But if you stop your fentanyl during this process, you might have significant withdrawal from that as well. And they talked about the supplemental medications to treat withdrawal symptoms. So they did counsel people that precipitated withdrawal was a possibility. The trial had some strengths and some weaknesses. So some strengths, it was a novel protocol and a very unique data set. I thought it was clinically relevant. It was a big size, so close to 100 people they found to go through this protocol. 90% of patients initiated the protocol after choosing it, so really high uptake. And they had a strong outreach-based component. They really went anywhere where the patients were. I think they said in the paper that they went to supportive housing units, emergency housing shelters, tiny house villages, tent encampments, anywhere where the patients were. If the patients didn't come into the office, they went to them. And I think this was a strength and a limitation. It's a limitation because it means it's not as generalizable. If I imagine my own life in my own clinic, I really wouldn't be able to do this. So I don't think I've had as good uptake as they had. There's also a selection bias. Patients self-selected into this protocol, so they may be predisposed to do well with it and really chose it themselves, perhaps more likely to do poorly with other protocols that they may have tried before. They also didn't include any clinical outcomes. Overdose rates, fentanyl use, patient satisfaction, precipitated withdrawal, all they looked at was who stuck with the protocol and came back for that second monthly shot. Which in some ways is the bottom line. Like, if you can get people just on the medication, they're protected against overdose to some extent. They're kind of in treatment at that point, and that's awesome. But it didn't talk about how the patients themselves experienced the protocol, unfortunately. The other thing that they had that was different from what I would have in my practice is they had really easy access to medication. And again, not a limitation of the study, it's a strength of the study, but a limitation in terms of generalizability. Basically, the meds were patient labeled, as mine are, meaning that each dose was bought for a specific patient. But they had a specialty pharmacy that would get them the medicine within 24 hours. And sooner, if someone from the clinic was willing to walk to the pharmacy to get the medicine, you could get it right away, which, is totally different from my experience. I have to get everything sent by FedEx and often make multiple phone calls to ensure delivery. So that was the strengths and limitations. So I did think it was a valid trial. What did you think, John?
Yeah, I think it was interesting. I think I'm just trying to think of where and how I would use a protocol like this. I mean, I think that's my biggest thing. I like the idea of it. I just feel like generalizability of this. I don't know where. I guess my inpatient consults.
Well, we would need a big clinic, where you had many doses and a lot of staff, and we could really chase patients down. And it would be better if we had a buy and bill clinic where we had all the medication in stock, where we didn't have to order it and wait for it to come for each patient separately. That's my problem. Let's talk about the results. So basically, this was simple descriptive statistics. They just described what they did. So of the 95 patients who said they wanted the protocol, 85 of them, which is 90%, initiated the protocol. 75% completed the protocol. Eventually, some had to sort of start it a second time, but 75% got through that 3-day protocol, and 64% received a second monthly long-acting injection. So basically, the authors felt, and I agree, this is a promising potential pathway for patients to start buprenorphine, which is a life-saving medication. I mean, I think it's super impressive. Like, it speaks to their outreach that 64% of patients got all the way to a second month. That's better than a lot of other data and easier to reach populations. So will these help me in patient care? This protocol.
Can I ask you a question?
Yeah,
How
sure.
do they decide who got, between the two products? What was the split between the people that got the two different products?
Sorry, what were you going to say?
Was one favored? Because I'd be interested to see what perception is that would have left to what are people choosing?
Right. I mean, what they said in the paper, I don't remember there being numbers as to what percent got Brixadi versus Sublocade. They wanted to offer both because they felt that one of the products, which is Sublocade, had a strong reputation in the community and there'd be a strong desire for it, and patients were allowed to choose. But they thought it was just kind of reputational. It didn't seem to be based on anything other than that. Yeah, so finally, will the results help me in patient care? The protocol described in this study, which is overlapping injectable buprenorphine with full opioid agonist, it initiated buprenorphine in 61 of 95 patients, meaning that they chose to continue with the protocol, meaning that it was working for them. This is a huge success in a very difficult to treat population. And I think, like we said, the biggest barrier is administrative. I don't have the pharmacy access to get all 3 doses. I've heard that if I want Brixadi weekly, I could order all 4 doses at once, but I have no idea what would happen if I tried to get Walgreens specialty pharmacy to release 3 different buprenorphine shots, all labeled for a specific patient. I can barely get 1 shot out of them.
That ain't happening.
Yeah,
Right?
I mean, maybe I haven't tried. Dare to dream. I also don't have the outreach component. So patients actively using fentanyl and who are homeless, are they really going to come to my office on 3 consecutive days? And then there's the timing, I have different offices in different towns, so I'd have to sort of make sure I'm in the same office 3 days in a row just to meet the patients there. It just administratively, I personally wouldn't be able to do it. But I actually already have patients I'd like to offer this to. I think it's a great protocol. So in conclusion, for the right patient, I would try to deploy it, but it would be a lot easier with a little bit of a different infrastructure. What do you think, John?
Yeah, I think now that I'm thinking about this out loud, it seems like this has a great kind of niche for people with a higher severity that we currently can't capture, right? I feel like there's a group that, you can do I know we try to get away from the term induction, but there's a group you can start buprenorphine outpatient that do pretty well. And then there's a group that just can't tolerate that. And I think and they often get lost to follow up, right? Because they don't want to go to something more like inpatient or a methadone maintenance program where there's kind of more requirements. But this might be a good capture protocol for the group in between,
Yeah, well, and it's kind of self-binding in that the patient agrees when they're feeling strong and they want recovery, they agree to do the injection, and then they're covered for 4 weeks, You don't have
Yeah,
to
I
recommit
like it.
every single day. You just got to do it once a month. So, yeah, I mean, I'm a huge fan of the injectables, so the more ways to use it, the better.
Yeah, I like it a lot too.
Well, that's it.
Well, that was a really interesting article. It's certainly something, I guess, to put in the toolbox, right?
Yeah. And totally new. I haven't seen this data before. I mean, they've studied some of these in emergency department settings, but this is a great outpatient study.
All right. Well, thanks for presenting that. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are on the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from MyCares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.
Mint is still $15 a month for premium wireless. And if you haven't made the switch yet, here are 15 reasons why you should. 1, it's $15 a month. 2, seriously, it's $15 a month. 3, no big contrast. 4, I use it. 5, my mom uses it. Are you playing me off? That's what's happening, right? Okay, give it a try at mintmobile.com/switch.
Upfront payment of $45 for 3-month plan, $15 per month equivalent required. New customer offer first 3 months only. Then full price plan options available. Taxes and fees extra. See mintmobile.com.